Welcome, everybody. Thank you for spending some time with us today in this presentation. Our topic for today, topical wound oxygen therapy for diabetic foot ulcers during the COVID-19 pandemic. We are privileged to be with Dr. Freiberg today, who will be giving the presentation. A little bit of housekeeping before we start. Please submit your questions in the question box, and we will get to all the questions, or as many as we can, right after the presentation is over. At this point, let me introduce Dr. Freiberg. He is the medical director of DM Prevent Diabetic Foot and Wound Center in Dubai and the former chief of podiatry section at the Phoenix VA Affairs Medical Center in Phoenix. He is a world-renowned author and speaker, publishing over 100 peer-reviewed articles. He's been the editor of 2 textbooks, The High-Risk Foot and Diabetes and The Diabetic Charcot Foot. He is currently a director in the Association of Diabetic Foot Surgeons and is a fellow of the Faculty of Podiatric Medicine of the Royal College of Physicians and Surgeons of Glasgow. With that being said, let's move into our presentation. Dr. Freiberg, please take it away.
Okay, thanks very much, Matt, and welcome everyone. We're very pleased that you're with us here today, whether it be morning, afternoon, evening, depending on where you are in the world. We're very happy that you were able to join us for this unique presentation for a subject that many of you might have questions about, since this modality, topical wound oxygen, has been present in the marketplace for, believe it or not, over 50 years. However, we know that in the current COVID marketplace, with all the changes that have come into play, the world is changing. And we thought that this would be a good idea to bring this presentation to you at this point for a very nice home-based therapy for your chronic diabetic foot ulcers. These are my disclosures. These are my objectives. And I thought it would be nice to put forth this COVID-19 dashboard from Johns Hopkins University. This is just from yesterday, where we could see over 3.7 million total confirmed cases worldwide, over 260,000, almost 261,000 global deaths, with over 73,000 deaths here in the United States. So this has really taken its toll and has changed the world as we know it. Even in New York State has an equivalent number of deaths as the countries of Spain and France. So America is affected quite significantly from this pandemic. And as I said, it's changed our world. Public health concerns remain with distribution of disease, morbidity, and mortality. Health systems are severely strained with in terms of both resources as well as personnel. Healthcare provision has been severely impacted for all persons, that's patients and clinicians alike. We have new reliance on remote telecommunications and technologies, as we're using today. There's been a resurgence of home healthcare for point of service rather than on-site clinical care. Home-based therapies are the key to providing care in lieu of on-site care. The economic impacts are widespread across all the sectors, with stay-at-home mandates, unemployment, and business revenue shortcomings. And these problems affect both patients and providers. So now I think we're experiencing a new paradigm for healthcare delivery as well as prevention. This was an interesting paper by my colleague Lee Rogers. It was just published online, and I think it was very appropriate to mention at this point. And he's talking about the wound care center without walls, like a hospital without walls. And that the wound care center without walls is a strategy to untether wound care from a physical location and aggressively triage and provide care to patients with wounds across the entire spectrum of the healthcare system, utilizing technology and community-centered care. Now, how does this come into to play with our discussion on topical oxygen. Well, topical oxygen therapies are indeed home-based therapies. So I thought this was particularly pertinent to our discussion today. Now let's just get into diabetic foot ulcers specifically, since that's a topic of our discussion today. Now, this data comes from a paper in 2017, actually out of China, which was a systematic review of the epidemiology of diabetic foot ulcerations. And they determined a global prevalence of about 6.3%. And recognize every paper is going to be a little bit different, so we have to give some leniency here. North America, though, has the highest prevalence of 13%, and especially the USA, also about 13%. Now, this differs from other data points. However, this independent review found about 13%, with a confidence interval going from 8.3 up to 17%. And as you would expect, higher in males and type 2 diabetes and older patients, etc. So we also have to recognize the established risk factors for diabetic foot ulcerations. Neuropathy is always the key, but also peripheral arterial disease, deformity, and trauma. Duration of diabetes, the male sex, as we said, uncontrolled diabetes mellitus, prior ulcers, and prior amputations. This graph in the center comes from David Armstrong's paper in New England Journal of Medicine several years ago, showing actually the causal pathways that might lead to ulceration or recurrent ulceration in these patients. And we all need to be familiar with all these established risk factors. Although not all patients will have every risk factor, when they are present, we have to recognize their importance in that regard. So what about the treatment of the ulcerated foot in 2020? Well, this really hasn't changed all that much over the last 2 decades or so. The basic tenets remained the same. Always remove, determine, and correct the etiologic cause. Concurrent medical management of all the medical comorbidities is involved with these complex patients. Vascular assessment and revascularization to restore a pulse when necessary. Making sure you're assessing for and diagnosing infection, which sometimes can be occult, and performing proper incision and drainage, debridement, cultures, and adjunctive antibiotic therapy. And then we get to wound care. Wound bed preparation, debridement, offloading, dressings are pretty standard. And as we know, when there's a shortcoming or some kind of an impairment to heal over those 4 weeks that most of the wound care world has embraced, then we need to consider the role for advanced therapies, such as negative pressure therapy, such as cellular therapies, or topical wound oxygen, as we're going to talk about today. And then remember the important role of foot surgery, whether it be curative, ablative, or prophylactic, or emergent. Finally, once healed, we must talk about prevention. And that includes therapeutic footwear and constant surveillance. And of course, prophylactic surgery has a role even in the prevention phase too. So we all need to be well aware of all these basic tenets that haven't changed, and we must practice according to all international guidelines, which really embrace some of these basic tenets. But we mentioned advanced therapies. Now, this list is not exhaustive by any means, but these are just some of the more common therapies: negative pressure wound therapy, acellular tissues, various types of extracellular matrix tissues, or dermal or placental replacements, platelet-rich plasma, etc. We also have cellular tissues, autologous versus allogenic, and there are more and more of these coming on the market now. Tissue engineered substitutes, whether they be acellular or cellular. Growth factors, PDGF, of course, VEGF, FGF, and epidermal growth factor, depending on where you are in the world. These variable growth factors might be available to you. And then we talk about hyperbaric oxygen therapy as one of the best known oxygen therapies, which we'll talk about briefly. And of course, topical wound oxygen is one of the best home-based therapies as an advanced therapy, which is often adjunctive and should always be adjunctive to good standards of care, as we already mentioned. It's interesting at this time that we know that the 2019 Nobel Prize in Medicine was awarded to these three doctors for their research on how cells manage oxygen. And this didn't just happen in 2019. We've known for a number of years the important basis for how oxygen levels affect cellular metabolism and physiologic functioning as intimately involved in wound repair and regeneration. So it just seems very appropriate to make mention of this from last year. We know that oxygen is essential to healing across the continuum in all phases of wound repair, which is why standard of care, as we mentioned, is so important. We recognize its role in the inflammatory phase in producing the normal wound immune response and the upregulation of neutrophils and growth factors that help fight infection and prolong the inflammatory phase. The oxygen is important in the proliferative phase, of course, for the upregulation of growth factors, angiogenesis, synthesis of collagen by fibroblasts, etc. And of course, in the maturation phase, remodeling and epithelialization. Oxygen is needed throughout every one of these continual phases. So we recognize this is an essential cofactor if healing is to commence for the chronic or the acute wound. So again, oxygen is essential for wound repair and angiogenesis. ATP, oxidative phosphorylation, is the energy to drive biologic processes. It's necessary for the production of NADPH oxidase for that respiratory burst, the superoxide and reactive oxygen species production for bacterial killing, reactive oxygen species for intracellular and extracellular signaling for the growth factor activity, that upregulation of various growth factors necessary for healing. And of course, as we've said, oxygen is essential for collagen production. It's an essential cofactor for enzymes prolyl and lysyl hydroxylase. So we see that in all aspects of wound repair, oxygen is an essential molecule, an essential cofactor leading to the progress of our healing wounds. Now, we also recognize that chronic wounds have an oxygen dilemma. They are deficient, especially at the center of the wounds, due to disrupted or compromised vasculature, whether it be from diabetes, peripheral arterial disease, or trauma. Edema can impair oxygen delivery to tissues, as well as biofilms can impair exogenous oxygen diffusing into a chronic wound, or I should say ambient oxygen diffusing into a chronic wound. But the wounds also have a higher demand for oxygen, as we said, because it's needed to fight infection, for leukocyte function, for the respiratory burst, for the requirement for the synthesis of collagen, for the building of extracellular matrix, for neovascularization, for that respiratory burst that enhances this, the migratory ability of these cells, and also for their synthetic ability. So oxygen, as we've said, and I don't want to beat this to death, but oxygen is an absolutely essential part of the wound healing process. In this graph from Singer, from 1999, many of you might have seen, we can understand that while PO2 in arterial blood is about 100 millimeters of mercury, if we look down at the center of wounds, it drops down to below 10 millimeters of mercury. So there's really a strong hypoxic area here, which initially is a stimulus for neovascularization, but in chronic wounds, it becomes an impediment to neovascularization. So we need to correct that oxygen imbalance in these wounds if we are to progress in the healing continuum. So what therapies can correct oxygen balance, or I should say imbalance? Well, we've already mentioned full body hyperbaric oxygen with 2.5 atmospheres of pressure, which is constant to the entire body. And we know monoplace versus multiplace chambers. It's limited to HBO facilities. This is certainly not a home-based therapy. Specialists are needed with special certification. And there's a number of contraindications and complications from this. Topical wound oxygen, can have either pressurized or non-pressurized devices that are applied directly to wounds with sealed chambers or sealed dressings or sealed cannulas. And these are home care therapies. They're ideal for the current situation that we're in. These are easy to use. Patients remain fully ambulatory, and some self-administration of these therapies is certainly possible. There's no absolute contraindications. We've also seen the advent of oxygen releasing agents or dressings or even hemoglobin sprays for oxygen transfer. Again, these are useful either in the home care setting or in the wound clinic, and there is no absolute contraindications. The UMA, in a project led by Finn Gottrick out of Copenhagen, produced this document, as you can see here on the right, which explores the use of oxygen therapies in wound healing. This was published several years ago, and it might be of interest to the audience. So let's talk about these oxygen therapies again. And of course, when we talk about oxygen therapies, throughout the world, many people think of hyperbaric oxygen first. Well, while hyperbaric oxygen therapy is well established and well researched, the data is inconsistent, and its efficacy in healing chronic DFUs is certainly disputed more and more, as evidenced by the recent failed Dutch Damocles HBO trial by Santima, published in 2018. Just last month, a new systematic review for non-ischemic diabetic foot ulcers determined that there was no efficacy for non-ischemic diabetic foot ulcers, and there was no significant reduction in minor amputations or major amputations. Hence, HBOT is not endorsed in the ADA standards of care in 2020 due to the mixed data. It is not endorsed by the UK NICE guidelines for the same reasons, and yet the International Working Group of the Diabetic Foot in 2019 gave it a weak recommendation, despite the disconnect between the other agencies and associations around the world, perhaps because they had a strong hyperbaric proponent on their panel. I don't know, but it was questionable why they did this. Now, getting to topical oxygen, which, by the way, many of these agencies, or I should say associations, had not fully recommended because of the lack. They found that it's still controversial despite 50 years of use and over 30 clinical reports with positive reviews in the literature. But the question of controversy remained because there were no high-quality RCTs yet published to establish the efficacy of this very, very useful modality. There have been studies, prospective studies, and there have been some RCTs, as we'll see, but no high-quality RCT that in combination with the other available evidence could absolutely support the efficacy of this modality. We have to recognize that topical oxygen devices are not all the same. There are different types of devices. There is the non-pressurized continuous diffusion of oxygen, as we can see in the panel on the left, some with negative results, some with mildly effective results, as we'll see, some with trials still ongoing. You have the low pressure, low constant pressure device here, which most of us haven't really seen, but they have undergone some animal studies in the past. So this is available as well. And then we have the cyclical pressurized topical oxygen therapy, which is one that we've studied and we'll talk about more. And this cycles oxygen from 10 millibars up to 50 millibars throughout the course of a 90-minute therapy. And the pressurization allows oxygen to diffuse deeper into the wound tissues due to the higher diffusion gradient. So it makes sense to have some pressurization of this oxygen. And the cyclical pressure can reduce edema and stimulate both perfusion and exudate production and eliminate that exudate. So these are the different types that we'll see on the marketplace now. But again, we've studied this one fairly extensively, and I'll be talking more about this device shortly. Now, is there an evidence any evidence to support a biological effect of topically applied oxygen? This is the key question, especially that many hyperbaric opponents of topical oxygen would be asking. Well, this is because there have been some fairly poorly designed and executed older trials that showed no effect, i.e. the infamous Leslie trial published in Diabetes Care in 1988, a trial that now even the lowest quality journal would not publish because of the great weaknesses in the trial execution and design. So we really have to discount that in modern times. But also confusion regarding different devices and different delivery systems. Are they similar, or do they have different effects? And again, we're talking about continuous diffusion of oxygen devices versus the pressurized devices. Now, most studies are case reports or case series on both DFUs as well as VLUs and some pressure ulcers that generally provide positive clinical results versus comparators in a variety of wounds. Now, there has been one negative CDO RCT in University of Texas 1A diabetic foot ulcers published in 2017. Contrast that with another CDO device and an RCT showing efficacy in UT1A diabetic foot ulcers. That was the study published in 2018. So we are seeing additional bodies of evidence in support of topical oxygen for chronic diabetic foot wounds. And even several animal studies have demonstrated positive clinical and histological as well as biochemical findings supporting a definite wound healing signal. This is one of the animal studies. This one comes out of Tokyo, and it just shows on the back of a mouse wounds that were created. And over these wounds, you either had a permeable dressing or film or a non-permeable film. On the left is the non-permeable, and on the right is the permeable. And you can see in the pictures here, there's progress in wound healing, obviously, by allowing that permeable ambient oxygen to diffuse into the wound. And here we can see in the top graph, the permeable dressing allows for a higher oxygen tension throughout the 7 days of healing, as opposed to the drop in oxygen tension for the non-permeable wound. And in the bottom graph, we also see a great wound size reduction. So here's some independent clinical evidence that shows that even ambient oxygen can have positive effects on healing of wounds. But in my mind, this study by Fries in 2005 dealing with pig wounds showed that by placing 2 millimeter electrodes or oxygen electrodes 2 millimeters into the depth of these wounds and subject them to pressurized oxygen, that you were able to see a 10-fold increase in oxygen tensions after just 4 minutes. This was in the base of the wound itself. And then they exposed the open dermal wounds to topical treatment for about 7 days, and they took biopsies even up to 22 days. And they repeated this, and they saw certainly a gradual and significant decline in the size of the wound with improved wound healing in the oxygen treated wounds. Furthermore, when they did biopsies, now these are stained smooth muscle punch biopsies at 7 days post wounding. In this panel, we see the control subjects that did not receive the topical oxygen, and these are those that had the oxygen treated wounds. These were just ambient oxygen. And in VEGF, you can see when you contrast the controls to the oxygen, there's a significant upregulation of VEGF in green here at 7 days in the oxygen treated wounds. If we looked at smooth muscle actin staining, 16 days post wounding, we can see rather disorganized neovascularization and vessels, but here we can see a number of well-formed new blood vessels in the oxygen treated wounds. And here we can see by day 22, significant increase in PO2 of the treated wounds because of the enhanced angiogenesis and upregulation of the VEGF in these wounds, so they're better perfused even at day 22. So this was all independent data, and it does show a definite wound healing signal and response in these pig studies. And I should say, a very nice study was also done by Gail Gordillo and Chandran Sen when they were at Ohio State University, where they also found that topical wound oxygen therapy increases VEGF expression significantly from baseline. And they even compared this with hyperbaric, which they did not find a significant increase. So it was very interesting. And this FGF2 expression was from a study by Scott in a poster in 2009. So we're definitely seeing a wound signal here. Upregulation of VEGF, enhanced angiogenesis that supports what we see clinically with improved wound healing. If we look at the punch biopsies here, again, we're seeing in the treated side much more normal and less hyperproliferative epidermal response here, with more of a normal appearing structure here. And this is granulation tissue showing in the bottom staining here, much more organization of the collagen that's being laid down. So we're seeing a more normal architecture here in the oxygen treated wounds compared to the rather disorganized architecture in the controlled wounds. So again, more independent evidence of a wound healing effect of topically administered oxygen. I don't want to go too far into these other studies, but this is also from the Gordillo and Sen laboratory. This was just a retrospective review of 9-month clinical case series of a variety of wounds who were treated by their surgeons with topical oxygen, and they found that 38 of the wounds in 15 patients healed with a topical wound oxygen. So we can see about 72% of the overall group of wounds were healed with the topical oxygen therapy. Several were lost to follow-up. So, you know, this is just one of those case series. It's retrospective. It's not hard evidence, but still it is evidence that supports a positive effect of topical oxygen therapy for chronic wounds. This non-randomized study by Blackman out of Canada was prospective controlled study with topical oxygen patients versus standard of care patients, 28 outpatients used to conduct an assessment of effect of topical oxygen on wound healing for these diabetic foot ulcers. And what they found is that the proportion of wounds healed at 12 weeks was significantly better in the topical oxygen group than in the standard dressing group, which contains silver. So we can see a significant difference in days to complete closure here between these two groups. And I like to look at Kaplan-Meier curves because it can really tell you the separation and the point at which the two groups can separate, and it really tells a story. And we'll look at another very important Kaplan-Meier graph as we move along here. Here's one that I mentioned earlier from the continuous diffusion of oxygen study that was published in 2018. This was for UT grade 1A only ulcers, and these patients were also followed for closure at 12 weeks. They all had identical offloading to Bremont standard of care, but it wasn't strictly analyzed with the intention to treat cohort, meaning once a patient is randomized, that patient is followed through from the beginning to the end, as long as they've received one treatment. But even so, in their reported results, 32% versus 16.7% healed. So this was significant at 12 weeks, and this was randomized and blinded, I should say. They found an increased time to wound closure, 50% wound closure in the active group as well. But unfortunately, there was no 12-month outcomes reported, which is really what the FDA is looking for now for wound healing studies, not just 12 weeks or 16 weeks or what have you, but also long-term healing, i.e. 12 months. So in that regard, we published the results of our randomized controlled double-blinded study in diabetes care. It was first published online in 2019 and just published last month in March, or I should say in March of this year. And this protocol was intentionally designed to overcome the shortcomings of other earlier studies in both the DFU and topical oxygen space. So what about the device that we use, topical wound oxygen multi-modality therapy? You can see a picture of it here. We used an extremity chamber that was provided 100% oxygen. It addressed stalled inflammatory processes, addressed the impaired immune response due to lack of oxygen and upregulation of reactive oxygen species. It promotes neovascularization and angiogenesis, as we saw with the old Fries study. And of course, this enhances collagen synthesis. The cyclical compression reduces edema, which might alter the dynamics of flow of nutrients and metabolites. Positive pressure enhances oxygen diffusion, as we've said, and I believe it's a stimulatory effect for neovascularization. It's also humidified, and the humidification provides for a moist wound environment and supports peri-wound tissues. So this is the multi-modality therapy that we used for our study, which is a little bit different than the other studies. So this was a state-of-the-art, sham-controlled, double-blinded RCT using this cyclically pressurized topical wound oxygen to heal diabetic foot ulcers that had failed to heal with good standard of care. Now, this is a multi-center, multinational study across the USA and Europe, because we wanted to have a broad spectrum of clinicians and patients involved in this study. I don't want to get too heavily involved in inclusion criteria and exclusion criteria. They're fairly typical for DFU studies. But what we did, which is different than most of the other studies and most other DFU studies in general, is that we allowed for a University of Texas grade 1 as well as 2, from 1A to 1D and 2A to 2D. To be evaluated and enrolled in our study. We also dropped down the ankle brachial index cutoff level from, most studies are below a 0.9, you're excluded, but we allowed above a 0.7, but we also required an additional measure of perfusion, such as a TCPO2 of greater than 30, or toe pressures greater than 30, or skin perfusion pressure greater than 30 millimeters of mercury. So we had to have both parameters here, but we wanted to expand and broaden the inclusion criteria so that we would have more difficult patients being able to be enrolled. And of course, we used a 2-week run-in period, as any good diabetic foot ulcer study requires. We did exclude patients with documented osteomyelitis, uncontrolled diabetes, over A1C of over 12%. And we excluded dialysis patients, but we did allow patients with creatinines of up to 2.5. So this was a little bit broader than one would usually see in many of the DFU studies. We used a group sequential design that a priori allowed for 3 predetermined analysis points with hard stopping rules at 1/3, 2/3, and a complete number, who completed a 12-week treatment phase. And because we did interim analyses, we had to use the Pocock stopping rules, as well as the reductions in the alpha levels, making each alpha level had to be, rather than 0.05, was 0.022, because we were doing these interim analyses, which made the results harder to achieve, a significant difference between groups, because we placed a lower p-value in order to achieve that significance. Again, we provided for a 2-week run-in period with very good optimal standard of care, I would say, probably the best offloading device available on the market. And only those patients with less than 30% wound area reduction after those 2 weeks were randomized. And once these patients were randomized double-blinded, meaning that the patient nor the investigator nor the coordinator knew to which study arm they were enrolled in. These patients were followed to the end of the treatment period, at the end of the 12 weeks. If they dropped out, they dropped out, but their last results were carried forward. Very, very important to do intention to treat analyses on these studies. The therapy was administered 90 minutes a day for 5 days per week, and this was determined by other independent studies that had assessed that a minimum of 5 days at 90 days is probably the most useful dosing and frequency to achieve the desired results. Again, our primary endpoint was ulcers achieving 100% healing at 12 weeks, and we only did an intention to treat analysis. Many studies do per protocol analyses because all their patients don't follow all of the prescribed treatments or protocol. We did not want to do that. We wanted to make this study as robust and as tight as possible, so we only did ITT analyses. Secondary endpoints, especially looking at the 12-month incidence of both recurrence as a measure of durability, as well as certainly complete healing. We also did cardiac wound impact schedule for quality of life assessments, and of course, adverse events and incidents of amputation. So our intention to treat results at 12-week healing. We found a very strong, significant statistical significance in the study arm versus the sham arm at the 12-week point for 100% healing. And here we can see a very significant p-value. When we adjusted for University of Texas grade, meaning grade 2 versus grade 1 as part of our adjustment in the logistic regression analysis, we delivered an odds ratio of 6. This meant that when adjusted for severity, University of Texas grade, those treated with the active therapy had a 6 times likelihood of healing at 12 weeks compared to those in the sham therapy. That was pretty strong results. Now, if we also look at the likelihood to heal over 12 weeks using a Cox proportional hazards modeling, also adjusting for University of Texas grade, we saw this produced a hazard ratio of over 4.5. So over the course of 12 weeks, patients in the active group were 4.6 times more likely to heal than if they were randomized to the sham group. Now, as I mentioned before, the Kaplan-Meier graph tells the whole tale. And here we can see a beautiful Kaplan-Meier graph here, whereby we see time to healing over the course of the 12 weeks. Now, what we see here in the active group up here, we can see a rapid rise to healing at the 12 weeks, and we see here a significant separation in the sham group in the blue down below. What's important here is that there's a separation between these two groups right from week 1, and they never cross. And I think this really tells you the story. There is indeed a signal starting as early as 14 or 20 or 21 days that just moves on entirely through the treatment period, and the groups don't cross. So this was significant, as you see here by the log rank test. More data to support a very positive effect of this multimodality therapy. Now, if we look at larger wounds greater than 4 centimeters squared, this is all comers, including those who have healed or those that remained open at 12 weeks. We saw on the left an overall reduction in size of 64% over 12 weeks, compared to the sham group, where there was an actual increase in size by 2% over the 12 weeks. And of course, this was significant. You can see the curves here over the course of time in both groups. So again, further evidence even for larger wounds. Remember, we included wounds, or inclusion criteria were greater than or equal to 1 centimeter up to 20 centimeters squared. But this is just for the larger groups. So the entire group, we saw positive results, and even in the larger group, even if they didn't heal at 12 weeks, we saw a significant reduction in size. Very, very strong evidence. Now, these two bar graphs contrast both the primary outcome at 12 weeks and the secondary outcome at 12 months follow-up. And of course, we can see, as we said, 41.7 versus 13.5% healed at 12 weeks. And at 12 months, we saw the similar relative effect where 56% of the active treated patients were healed long after they stopped the treatment, by the way, at 12 weeks, compared to 27% in the sham treated group. And what's interesting is there's about a 29 percentage point difference in both groups. Let me go back, sorry, in both groups, both in the active therapy treatment phase here, about 29% difference compared to 29% difference at 12 months. So we saw a 68% margin of effect and a 300% relative performance at 12 weeks. And we saw a 52% margin of effect carrying forward even at 12 months with a 207% relative performance, at 12 months. So there's a positive signal that's carried not just through healing at 12 weeks, but extended even beyond that time. So I think the early signal really made a significant difference. And although I'm not putting it in a graph here, we saw a 6-fold reduction in recurrence rates in the active versus the sham treated group at 12 months as well. So we saw durability of healing and progressive healing in the actively treated group that was significantly better than in the sham treated groups. So in conclusion, this robust RCT demonstrates that cyclical pressurized topical wound oxygen significantly superior to gold standard of care alone. And we used the best standard of care in both groups that we possibly could. And remember, patients were 6 times more likely to heal at 12 weeks in the active group compared to the sham group. The larger DFUs also had a significantly greater percent wound area reduction at 12 weeks compared to the sham treated group. We provided for robust long-term healing, excuse me, as I said, because we had significantly fewer, or clinically significantly fewer recurrences. We found, and patients found, that this was a very easy to use home care therapy with high patient compliance. We had about 95% therapy compliance, and we had about a 95% offloading compliance, which is almost unheard of in most diabetic foot ulcer studies. So we believe that this supports consideration as a frontline adjunctive option for non-healing chronic DFUs. And I underline adjunctive because you must provide for excellent standard of care if anything is to work. Otherwise, you'll be futile in your efforts. So this is adjunctive, as is any advanced therapy, adjunctive to good standard of care. So in summary, also, topical oxygen therapy significantly raises wound surface tissue oxygen levels. It raises the central wound PO2 levels by direct diffusion. It increases VEGF expression, which promotes angiogenesis. It helps suppress bacterial growth by contributing to ROS generation. Excuse me, increased local PO2 levels allow, of course, for increased oxygen synthesis. There's evidence from multiple animal studies and case series to support a wound healing benefit, even besides this RCT that was just presented. But RCT that we did provide gave us level 1 evidence that this cyclical pressurized humidified TWO2 device can significantly heal more DFUs versus standard of care at 12 weeks as well as 12 months, very importantly. And larger wounds had significantly reduced wound area reduction versus the sham controlled wounds. So I think this level 1 evidence really surpasses that of currently available topical oxygen therapy and even hyperbaric oxygen therapy that has yet to achieve similar results at 12 weeks in a really robust, well-designed trial. And I wanted to mention that topical oxygen is complementary to other adjunctive modalities that you might like to use because it provides for a robust granular bed, stimulates angiogenesis, increases growth factors, strong interlaced collagen that helps result in a better wound repair. And if you want to apply these types of grafts or prepare your wounds for subsequent flaps or skin grafting, or to apply another advanced therapy, this makes an ideal way to manage your patients at home until you can get them into your clinic to either apply a skin graft or a flap, or to apply one of your other advanced agents. So it can work in conjunction with anything that you like, including if you want to put a patient in a cast. This will still diffuse around and through a cast. So with that, I want to thank you, Matt. I hope I didn't go too long, but I had a lot of evidence to go over, and I hope that I've generated some kind of questions from you. We expect that this information might be new to you. Hopefully it's eye-opening to you, as it has been for those of us who have used topical oxygen therapy over the years. So we look forward to answering any questions that you might have. And again, thank you very much for joining us on this webinar today. Thank you. Okay, Matt, I'll turn this over to you.
Okay, thank you, Bob. Thank you for that. That was a great presentation with lots of information. The study that you described is fantastic, and it was just published, as you said, last month. We do have a few questions in the pool, so let me start. The first question is your experience with topical wound oxygen and skin substitutes, and I think you hit on that right at the end. The question was, do you notice any difference in any other skin substitute versus another? And I'll let you answer that before I do.
Well, okay. Well, the person who asked the question is very astute, because, as I said at the very end, this technology lends itself very well to be used adjunctively, not just with standard of care, but with any other type of tissue product that you might like. Because remember, it produces a robust bed of granulation, a really jumpstart these wounds to allow them to rapidly heal. Remember, the increased VEGF, increased angiogenesis, increased tissue oxygen tensions because of the increased angiogenesis, building a good bed of granulation on which you can lie a skin graft or any other advanced therapy. But I'll caution you, there really hasn't been any number of comparative trials from one to another or in conjunction with topical oxygen, but experience that we've had has shown us that yes, this can be very, very helpful. So Matt, you had something to say on that.
All right, that's great. We noticed that it does indeed help. These products work better and faster, so as a result, you need to use fewer of those types of products. Before I go any further, and please, anybody that has questions, put them in the question box, and we'll be able to address those. Let me give a thank you to the folks at Advanced Oxygen Therapy for their unrestricted educational grant that made this presentation possible. And let's see if we have some other questions here. I have one. How can we take advantage of the wound center or the wound center without walls when we're using topical oxygen?
Well, I think basically it fits very nicely into this. This has always been a home-based therapy. All patients utilize this at home. In fact, in our trial, no therapy was ever delivered in the clinic or in any wound center during the trial. It was every treatment was done at home. Now, this device is delivered to a patient's home. The patient is trained on how to use it, and then the patients can deliver the therapy themselves for each day, 5 days a week, for 90 minutes a day. It's just putting their leg into an extremity chamber and making sure that the upper part is fully sealed, like with a Velcro wrap. So it lends itself perfectly to this, where the wound center without walls now is focusing on telehealth, telemedicine, as well as community-based care. So with a new app, with FaceTime, with the specific apps, you can actually look at that patient every week or every day for that matter. And I think that might even be an advantage. If the patient knows you're going to be looking at them more than that once a week visit, they're probably going to make sure that they do well, because they like to please their clinician and their doctors. So you can look at the wound, discuss the therapies with the patient, and probably get around any difficulties that they might be having. And of course, if there's a problem with the device or with the seal, which sometimes can be a problem, the representatives can go out and try to figure out what the problem is. So that's been our experience anyway.
Okay, I think you bring up a good point about the telemedicine and telehealth that's going on now. With this device, you can actually use it at home. You can follow up with the patient using the codes that have been provided, because now the telehealth codes have the same reimbursement value and same RVU value as our visit codes. So we're not losing anything whether we use the televisit codes or our regular visit codes when we follow up with these patients at home. So that's something that's very convenient. I had another question for you, Bob. With the do we need to actually see our wound care patients in our office, or can we simply prescribe this to them while they're at home so they can begin using it?
That's a double-edged sword there. The question is two-sided. Yes, but remember, this is predicated also upon having excellent standards of care, which means you must be sure that that wound is fully and adequately debrided. You must be sure that those wounds are not terribly ischemic. You must be sure that the patient is practicing good wound care each day, or however you decide to do it. And you must be sure that they are adequately offloaded. Correct. You know, a lot of these people will just walk around in their barefoot or slippers at home, and we know that that's not good enough. So it's very, very suitable for home care. And yes, you can just prescribe it, and it can be delivered to the patient's home, and the technician will train the patient, on how to deliver the therapy. They're not going to do any wound care, but they just show the patient how to do the therapy. So I think this technology is perfectly ideal for the new paradigm in care that we're seeing right now as a result of this COVID-19 pandemic. But remember, these types of therapies have been present for 50 years. It's just that now we're seeing that the evidence really supports what was seen in other types of lower level clinical studies, all leading to a positive result, which is why we had to do the RCT to show definitively that yes, there's definitely a signal here, and this stuff definitely works, no matter what your local skeptic or opponent to topical wound therapy says. And what I like to say is, when we designed this trial years ago, I had in mind those skeptics, the hyperbaric opponents who are going to try to put the nail in the coffin of any topical wound oxygen study. And so we tried to make it as airtight as possible. That's why, if you can believe it or not, even that latest trial, the Santima trial, was not even sham controlled. It was just with standard of care. Why would they do a trial that lends itself to sham therapy and just use a standard of care? So, and as I said, many of the other trials for HBO, they just haven't shown the result. And so HBO cannot be delivered in a home. It doesn't have the evidence that topical oxygen has, and this is ideally suited for what we're talking about right now. I'm sorry, that's a little bit long-winded, Matt, but it just goes to show how well suited topical oxygen therapy is to home-based therapies now, especially with telemedicine, as you mentioned, and the ability to use relaxed requirements for video conferencing and telephotos and imaging and everything. It's just perfect.
I think you hit the nail right on the head. I think that we're entering a new paradigm with more home care. This is a perfect fit for home care. It accelerates wound healing, accelerates use of the products that we're using for wound healing. And we've noticed that when we first apply this type of topical oxygen, which I should say is much different than the topical oxygen we heard about years ago, the RCT shows us that this is very, very effective in healing wounds, that we see a jump in wound closure on initial application. And so this has the ability to jumpstart those wounds and get them to begin healing because of what it does to the wound bed in oxygenating it.
Exactly.
So I don't think we have any other questions. I think we're in good shape at this point. So in that case, I'd like to thank everybody for joining us on this presentation. Thank you, Bob, for a great presentation and talking about the RCT. And be sure to tell your friends to tune into this later and see it remotely when they get a chance so they can learn about this amazing technology. And with that being said, we'll sign off. Thanks, everybody, for listening.
Thanks very much, Matt. Great job.